Dr. Riaku, please, can you help me to try to promote other people to panelists? I've been trying, and it's saying declined.
Good morning. Who do you want me to promote? Professor Priska and others.
All others in the participant list.
Yeah, let me do that.
Good morning, we are welcome. 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 Good morning, we are welcome.
Mr. Shola, this Priska is Professor Priska.
Yes, she is, but she has entered with. She entered before with another.
Yes. But I don't think that other number is still there. That name is no longer there. So should I promote this?
I've been trying to promote this.
Even Ijoma Misu does have tried to promote.
I've been trying out to. It didn't go. You keep saying declined. Even throughout yesterday, it was saying.
Okay, so I should promote the Priska now.
Yes, I'm also trying here too.
Oh, okay.
Shall I?
Prof
Is
is
that
in now. Prof
eh?
is in now. Prof
Me,
is
I've
now.
been in. I've been in.
He
I
has
was the
been,
first to be in.
he was the first to come. Yes.
No, I mean Professor Priska. She's back now.
Oh, yeah. She's there. She's there. Priska Dejuma.
Yes, she's there now.
Hello, sorry, I was muted. I went downstairs to bring an extension. My charger is not working.
Prof, you have two devices on, so it's causing echo.
Me? Not me or not mine.
No, and you can't mean.
Professor Prisco.
I want to make sure that the laptop connects as a panelist before I discontinue the phone. Okay, good morning, everybody. Prof, please pray for us.
Myself?
Yes, sir.
Hello? Okay. Heavenly
Yes,
Father,
yes,
eternal
yes, sir.
rock of yes. Shall we pray in Jesus' name?
Amen.
Our Lord and our Father, eternal rock of ages, we come before thee this morning again to glorify your name, to praise you, to let you know that, Father, we hold you as our Lord and our God, because you have sent us on this errand of equipping your people with the knowledge and the skills to live a useful life. We thank you for the gift of life unto all of us. We thank you for the knowledge, the opportunities you have granted. We thank you for what we have done successfully. We thank you for what we want to do now. And we commit it into Almighty hand. Take absolute control. Let everything go perfectly. Let there not be any technological itches or any human errors or any error in any form. That, Father, the purpose for which this workshop was established will be fully fulfilled in the name of Jesus. At the end of it, you only shall be glorified. In Jesus' mighty name we pray. Amen.
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 Okay. Good morning, and thank you, everyone, for the sacrifice and all. One, I'd like us to answer the question that I think is Madam Ijoma who put it there, because it seems that if she does not resolve this, she may not be able to finish up with the post-test. And I'm strongly thinking that maybe we should not do the post-test today. I don't know how you feel, but let's answer the question first. I think it's question 42. She screenshot it and put it on the LOC platform so we cannot check it. It says, what cultural belief discourages genetic screening before marriage? I don't know whose question that is. Best thing will have been
It's
question
Professor
42 is on.
It's B. I've replied her. It's B.
Ojengbe's question. Okay.
Yes.
Viewing it as an interference with divine will. Okay. So have you replied her?
Yes, my
Okay,
okay, thank you. I'm just seeing
Yes,
it.
ma. I've effected it, ma.
Okay, thank you. Do you have the link for the post test already?
Yes, ma. I've posted it also.
Has
on the
anybody attempted doing it? I didn't see it. Me, I'm just coming up now. Sorry for that. Has anybody attempt doing it at all? I didn't even see it. It's very important before we put people through anything, we should be able to do that thing. It's just a principle of program management. I'm sorry for all this, my stress. But if we don't do it and know if there's any itch or any...
Priska.
Yes, sir.
Sorry, please. I just want to give this piece of information in case we decide to do it. If we decide to hold the post test next week, the webinar will still be on. It's going to expire July 20, which is a Sunday. So I was able to get an extra 1 week in case we choose to do it next week. We still have it on. Thank you.
Okay, thank you. I'm strongly. I can't find the link, Madam Ijoma. Where do you say you put it?
On the LOC, but I've also sent it to you just now.
Okay, but I'm looking for it on the LOC. Please, everybody, have you checked the link for the posters on the LOC? Can we look for it and try to do it? I don't want to be the only one. I want to make sure that participants, irrespective of where they are. Okay, I think it's time for forms open. New D43. Okay, maybe it's this link. Okay.
Ma, I have a concern.
Yes.
If we
Okay.
don't do the test today, what happens with the hands-on that we have planned for next week? How do we determine who goes in for the hands-on?
That's very good. That's a very good one. Madam Ijoma, can you please remove the timing that we put? That means we have to do it. Okay, let's encourage one or two people to quickly do it, so that we can be doing. I can face other things. Please, can I have people just start doing it as I'm doing other things? I feel like there's a way you handle post-test, and we've not been able to handle it because of series of issues and itches here and there. And if it is important that everybody should pass and score higher than the pre-test score, otherwise it invalidates all the knowledge and the exposure that people have been exposed to. Maybe it's my personal prejudice or fear, and I don't know. Normally, after the pre-test, before the post-test, it's important that one, we ensure that all participants have access to the materials that they need to read. Two, we need to ensure that if there's any easy part of it, we clarify before the test starts. And just to be sure that everybody is on good page, and then we can start. But this one, there have been almost every week new dimension of of technical issues. It's nobody's fault, and we're all human beings. Even machines are beginning to fail, so there's no point thinking that things will always go perfect. That's why we're humans. Okay, so maybe we should just say, so who is doing it, please, so I can face on the next 4 minutes to quickly see where we are regarding the agenda. Ms. Ashola, where is Prof's file? You are doing the pre-test, Abi? Dr. Kotila, you are doing it, Abi?
Yes, I'm on it, ma.
Thank you. Thank you. Thank you. Okay, so I'll leave it. I was doing it before, but I need to spend 4 minutes on this. Where is Prof's profile? Who has it?
I sent it to you yesterday, man.
I didn't say it. I don't like the way it is very wrong to have people speak without introducing them. Number one, it gives people opportunity to know who they are talking with. It's not everybody who knows all these people. We will correct all of that in the. Okay, I've just seen it now. In the what's the name? That not everybody know the people. All of us at home, yes, we know Professor Ojengbe. We know some of us know ourselves. Like me, I just choose not to introduce myself because the anxiety I had that day was more than I don't know how to describe, when we couldn't find Obi, and then the time also. But it's okay.
Hello, ma.
I've seen
Sorry,
it.
ma. A quick
Yes.
observation on the post test. So,
Yes, go ahead.
by the time we start the questions, yes, ma. In starting the questions, the numbering starts from 60. I hope it's okay like that. So they know
It's not okay though.
it's.
Oh, yeah.
So
Please,
because it's shuffled,
take
the first question is starting. So it's showing the scrambled nature that the pre-test numbering format is still what is on it.
Madam Ijoma, that one is done to make marking easier, but we don't have to do it like that, because it means that after they finish answering, you have to reshuffle again.
isn't it?
Google Forms does not have numbering, actually. There is no numbering for Google Forms. So those numbers are not actually numbers in the way we think. They are just like part of the question, like one, full stop, what is so thing. So the only way to make this thing not to have numbers, not to reflect that way, is for me to go and delete all the numbers. And then that way we will not be able to trace which question is which. So it's going to have to be like that. And the shuffle is not even the same for everybody. So our own is starting from 60. That person's own is going to start from 3. That person's own is going to start from 25. So that's the
Okay,
only
so
way. But Google Form is not
let's
like
just leave it.
Word.
Go ahead.
Yes.
Let's just go ahead. Go ahead.
Professor Priska.
Yes.
I have to send the link out to people now, so they'll be able to
Please
join
go
this
ahead.
room.
Please, there's nothing we can do. Go ahead. What we want to talk about now is not for them. So if they can join, let them join. Everything about post-test has been taken care of. So we can go ahead. And
So what is the cutoff?
We can't
for those that will choose
can't decide all those
participate in the hands-on.
until when we get the results. So immediately after this, we meet. We will know the highest.
Discussion should still continue as people joining.
Hello.
What do you say? We cannot determine all of that now until after. We have 5 minutes more. After the session, we will come back for scores. So whoever is retrieving the scores will retrieve it immediately. We look at the highest or the lowest difference. We look at everything we are going to look at. We have to look at it. It's not the best, but there's nothing we can do.
Yes. Hello. I wanted to say that I adjusted the settings so they can actually see their scores. So just to back Professor Priska up, it's not a good idea to announce what the cutoff is in case the results come out and then maybe you want to do a less cutoff or something, because everybody will know their score. So if you say it's 30, then you have plenty of people emailing you saying I had 30. So because they can see their results when they have submitted.
Okay, is there any other thing? Any other thing before I...
Yes, ma. Mr. Shala was also saying yesterday that it won't be possible to take a picture on this webinar.
It's okay. I said we should take picture. We should take the picture of names like that. It's okay. It's also valid. Instead of if we can't show our faces,
the program managers should take note.
Take the picture of the name. I mean, screen. However, that one was done yesterday. Let's go ahead and do it. Like that. I don't know whether you understand what I'm saying. Please, today is 12, Abi. And today is 11.
Yes, sir.
No, sir. Today is 12.
12.
Today is 10?
No, today is 12.
12.
Oh, 12. Okay.
Yes, sir.
I'm adjusting the agenda. That's what I'm asking. Thank you. Okay, so let me quickly share it now. I can't even find my... Okay, I've seen myself again. Please, if you can see it, let me know.
Yep, we can.
Okay. So between 7 and 7:05, we'll have welcome and introductions. And then 7:05 to 7:55, it's supposed to be 7:45 because it's 40 minutes. You need more time for the I can still leave it to 8:10. No. It's not question and answer. Okay, we need question and answer briefly. I'm sure they will not be listening to all those question and answer. That's 15 minutes. Please help me to check if what I'm writing is wrong, is right or not. Then from 8 a.m. to 8:40, 8:50,
or even 8:55 and have the pre-test. Then we'll come and spend the last 5 minutes for. So they have 55 minutes. Is that it? But I think we should remove the timing, please. If there's any other question from Ms. Dr. Kotila, please work with her to effect that so that we can sort it out. I think I'm fine. Please, can you take a look at the agenda? I just changed week 4, day 2. Everything is here. If you have any comment, let me have it. Anytime from now, participants can start coming in. And
yeah, it's good.
Okay, sir.
So, when they're having the post-test, everybody just keeps watching. What would the LOC be doing? Do we have anything that we want to do in the background?
They will be asking questions
Just
they'll be asking questions and be responding to them. Please, everybody now, while Prof is presenting, go. Yes, no problem. It's 7 a.m. Okay, it's all right. Thank you very much. Good morning, everybody. You are welcome to the last day. Wow. We thank God for grace, for strength, for energy, for everything. His name indeed be praised. Today we are having week 4 and day 2 and Saturday, July 12th. So I welcome all of you in the name of the Almighty God, the God of Ghana and the God of Nigeria and the God of all nations. We are also excited that we have come to the end of phase 1 of this capacity building endeavor. Today we are going to be having an Emeritus Professor Oladosu Ojengbe, my mentor, speak to us and enlighten us and capacitate and empower us for every one of us to upskill, to add to our knowledge, and to improve in the area of practice as regarding sickle cell disease and community engagement and advocacy. Then Dr. Aniagu will be taking us through question and answer, and Madam Ijoma will be taking us through post-test evaluation, post-test, and we'll be taking post-test evaluation after that by Dr. Kotila. And then I'll come back to give us announcements and closing. Without further ado, we have just spent 2 minutes in doing this. I'd like to introduce to us our speaker for today. Like I said, is Emeritus Professor Oladosu Ojengbe. Is an astute man with over 30 years of experience as a professor of obstetrics and gynecology in the University College Hospital, Ibadan, the first and the best. He's a remarkable teacher, researcher, and a seasoned administrator. Professor Ojengbe rose to the peak of his professional career through professional qualifications and indeed arrays of other qualifications in leadership, in project management, in mentoring, and uncountable areas of human endeavors. Professor Ojengbe became the fellow of National Postgraduate College in 1981, West African College of Surgeons in 1982, International College of Surgeons in 1988, and capped it all with the very prestigious Royal College of Obstetrics and Gynecology in 2016. Currently, he's director of the Center for Population and Reproductive Health at the College of Medicine, University of Ibadan, with a focus on implementing training programs in reproductive health, maternal population, as well as newborn development health. He has contributed to the development of translational and interdisciplinary research globally through the development of new areas of research and training in different cross-cutting areas. When we talk of big fish, yes, I think it's the biggest fish in all interactions we have had on this project. Is our super mentor to almost all of us I don't know any that he's not a mentor to. He's mentor to all of us, including Obi, myself, and everyone. So he's a grand mentor. And it's my delight this morning to welcome him, share from his wealth of experience with us. Ladies and gentlemen, professional colleagues, I present to you Professor and an Emeritus Professor, Oladosho Ojengbe. Good morning and welcome, sir. Over to you.
Thank you, Priska. Good morning, distinguished participants, ladies and gentlemen, colleagues. It's my great pleasure to join this morning on this very important training that has been on sickle cell disease. Sickle cell disease has now become globally recognized as an SCD, and because we are far more in our region, more affected than some other regions, we should really, really take it seriously. So I will be leading us on the discussion on community engagement and advocacy for sickle cell research and services. Next slide. So why do we need to involve the community? All NCDs in diabetes, hypertension, all of them actually, all ailments require community input because there's always a cultural, a social, and issues involved in most of the cases of NCDs. And so we believe that through our discussion on community engagement and involvement, we will explain the importance of community engagement in sickle cell disease management. We will be able to identify key stakeholders, primary, secondary, tertiary stakeholders, and the roles they can play in improving the quality of care and access to care, and improving the overall quality of life for people who have sickle cell disease. We'll be able to identify advocacy strategies we can use and also highlight ethical and cultural practical considerations. Fortunately, I listened to Professor Adejumo's lecture yesterday, and that did dwell on that. So the outline is as listed here. We have 8 items, including the discussion. Next slide, please. So what really is community engagement? Community engagement is a process or a collaborative process that involves communities, the communities we want to interact with, where we want to engage our services, where we want to help our humanity, where we want to serve the people in the planning, implementation, and evaluation of either research or the services we want to provide. It will help us to recognize and mainstream the critical input of such stakeholders to enhance the quality and access to clinical services for stronger impact for sickle cell disease. Next slide. So we say that there's nothing about us without us. And like the Yoruba proverb says, you can't shave a man's head without him being there. And we do know that without their input, we jeopardize uptake of the services we want to provide. But if we include them in the planning and they plan with us, or we plan with them actually, because their input is just as important as the technical input we bring in, then we are planning for uptake of those services for sustainability and for major impact. Next slide. Community engagement in SCD increases the understanding of the subject matter by community members. It also dwells on the cultural sensitivity and relevance of the services we want to provide, because it's one thing to craft out a very effective service intervention. It's another thing for community members for whom you have designed it to take it up. We do have many, we know about many instances in clinical services where the major primary beneficiary, just do not agree and they don't take it up. Issue of family planning, for instance, is a very standard one to quote, you know. Then community engagement builds trust and encourages participation. I mentioned that before. And their participation enhances uptake and sustainability. Community engagement also facilitates identification of local barriers and solutions. I know that some of the topics we have discussed earlier in this course have dwelt on myths, all the myths about sickle cell disease, why it happens, what makes it happen. And without them understanding, our counseling, our genetic counseling will be of no value because they will be talking outside of their ears and brain. Next slide, please. Now, community engagement in sickle cell helps in engaging the community, ensures that the research and the services address the real contextual specific needs of the people in that locality, even affect their concerns and priorities of people affected by sickle cell. Yes, sickle cell is a standard entity, but environmental factors may make some, apart from technical interventions that work for everyone, other ancillary collateral interventions may not be a one-size-fits-all. So we need to engage them to be able to address their real concerns and also to make it culturally, contextually applicable. It also helps us to build trust and reduces mistrust. You know, that you remember sickle cell, we take blood, we want to check genotype. If you don't explain to them, they may think you are going to use their blood for other things, especially now in the days of ritual, engagement by people. So we need to engage, they need to understand what we want to do, why we want to do it, what benefit will accrue to them, and what is society or the community stands to gain from our supporting and bringing in interventions. Also, it will cause understanding local beliefs, that is we who are planning, so that we mainstream their concerns into what we plan. We take care of it within the plan that we're going to implement. And it allows for better communication strategies and improved participation rates by the community members. It fosters co-creation and improves implementation of solutions. Next slide. In addition, it enhances recruitment. Well, in the case of research, but even in the case of clinical services, it enhances when they understand and they are part of the processes of designing within the context of their knowledge of the clinical services, they understand it, then uptake improves. And really, one of the major challenges for clinical services and the health system is that, yes, you provide the intervention, but the uptake is very poor. Whether in communicable or non-communicable diseases, uptake is a major issue in third world countries. It also helps us to engage support, to get informed consent processes and respect local values, and ensures that the benefits of the services are equitably shared. I think that word equitably shared was discussed yesterday by Professor Dejumo. And that is true, because otherwise, then we leave some people behind. Because we who are planners, who are clinicians and providers, do not appreciate or recognize their peculiarities. But when the society and the communities participate, then we're able to have a better eye view of the spread and the pattern of the illness that we want to address. SCD is often surrounded by myths and stigma, particularly in African settings. Community engagement can support education awareness, behavior change efforts, reducing stigma, and promoting early diagnosis, care, and uptake of our services. Next slide. So now, I haven't mentioned what we want to achieve within the community by engaging them. Who are the key stakeholders, now specifically in sickle cell disease management? And a stakeholder in this case is everybody. Actually, for NCD, everybody, anything that have cultural rooting, that is well rooted in the culture of the people in the traditional practices. Every community member, from the household, from the individual to the immediate family members, to the household, to the community, to the society at large, is a stakeholder. But some are more strategically positioned, I think, depending on what you're talking about. In the case of sickle cell disease, community leaders and traditional religious influencers are very critical, because we know they come in when you have things like marriages, determining who you marry and so on. So when you get to a point where on the basis of genotype, a relationship may not go on, you need the people, the family member, the traditional rulers, and the religious leaders who do the counseling, who model, who preach, who run the services to also understand these issues. Marriage counselors, youth and school health educators, so that this education starts from school. We start to build the knowledge from childhood, from school, not when they are now adults and they've made up their minds on how to move on with their life. Healthcare providers who have the great opportunity of contact with community members, not necessarily because they have come for sickle cell disease care, for any care in antenatal clinic, in general patient departments, social workers, anybody, even pharmacists and so on. Healthcare providers, policymakers, research institutions, just as we are, media and civil society organizations, persons, of course, living with sickle cell disease, and care providers. Next slide. Next slide, please. Now, so having tried to identify the key stakeholders, we need to quickly run through the role of community leaders and traditional religious influencers, just as we've listed them. One, these are people, community leaders, serve as linchpins in disseminating accurate information about SCD within their respective communities. And this, one of the things we should encourage is that it doesn't have to be in any formal setting. Even in informal setting, when people are talking about social issues, when they're talking about health issues, when they're in, women's society organization meetings, to talk to them, and counselors who are trained. I remember also we said people want to do counseling, genetic counseling with people who are well equipped, so that we know the information we are passing on to them and information that will benefit them, that when they pass it on to others, they won't be misleading them. Also, leveraging their credibility and influence within the society, because they will be believed. They will understand them. They will respect their views and opinions. They organize forums and outreach programs to educate community members about sickle cell disease and available support services. And they encourage them to take up these services. That is another thing. And finally, they can provide culturally sensitive and linguistically appropriate education in language, in words, to empower individuals and families affected by sickle cell disease to make informed decisions about their health, thus bridging the gap in knowledge and reducing misconceptions and improving uptake of services. Next slide, please. Next slide. What about marriage counselors in community engagement for sickle cell disease? So when we go out at the end of the course, with all the knowledge we gain, we have great opportunity and a wide scope of people, of groups of people that we can interact with that can help with disseminating information about sickle cell disease and improving care. Marriage counselors promote genotype compatibility education. They have the opportunity to facilitate informed decision-making about whether a relationship should go on or not, helping them to take the informed, appropriate decision. Act as frontline educators during community meetings and faith-based gatherings and premarital classes, and also help mobilize religious leaders and traditional authorities within that community and family members to support responsible marital choices. In religious communities, counselors can help align spiritual beliefs, and I think this is very critical, spiritual beliefs with medical advice on sickle cell disease, and also provide support to couples who already have children living with sickle cell disease. We will also still come to that. They can actually be the needles or the points of developing community support groups, which we will still talk about, to help such families cope emotionally and practically. Next slide. What about the youth? I did mention that school health education should take the advantage of opportunity of catching them early, catching them young, to provide the necessary information for the children and youth so that they begin to grow as future leaders, as future counselors, for sickle cell disease. So the youth raising awareness among peers through health education champions, peer-to-peer influence promotes SCD champions, promoting genotype testing and encouraging colleagues and others to also submit for testing early by advocating for school-based testing campaigns is very important. And I'm happy that this is catching on. I know that some organizations, even religious organizations and so on, are promoting or inspiring their members to have yearly medical tests, checkups regularly. And so this should be extended to things like having early testing, especially for children, their genotype. Also combating stigma and discrimination through debates, awareness works, and creating competitions to challenge stigma around people living with sickle cell disease. And in fact, they can use social media as young people also. First aid awareness, promote school level preparedness to support students living with sickle cell disease, especially in the school health service, through hydration, avoiding stress and cold, and understanding their peculiarities. Using blogs, like I said, podcasts, TikTok, and so on, social media, and local radio to amplify advocacy messages that have been developed, that are being shared among the adults. They should share it among children, the young people too. The role of healthcare providers in community engagement, health education and public awareness, genotype screening and counseling, improving and referral, improving early diagnosis by identifying clinical signs and linkage patients to linking patients to appropriate care centers. Also, providing clinical care and management and other counseling to patients, to caregivers, and reduce shame or isolation. What about capacity building for their colleagues and training, and share clinical data and experiences to inform policy, drive research, and strengthen the health system, particularly at the local government level, which is the closest to the community. And then partner with communities in designing, conducting, and sharing research findings. This is similar to what we have done with FGM and GBV, where communities are taking it on their own, and they are co-creating, generating data to inform their people of the dangers of FGM, and so we can do the same. We can borrow the same template for sickle cell disease. Next slide. The role of policymakers and research institutions will include genotype testing, make it a mandate, a part of their mandate, support health insurance coverage, so that the greatest challenge, one of the greatest challenges to uptake of healthcare services is the large out-of-pocket expenses. Supporting health insurance coverage will help people to go for genotype testing and to also consult when there are challenges and complications. Promote participatory research, encourage research models that involve what is peculiar to that community, and also convene multi-sectoral stakeholders meetings so that they can rub minds, and including the NGOs, including ministries, the policymakers, and government institutions. And the use of media and fora and open days to explain research findings and promote public trust in SCD science. And finally, to translate that research, the data that we collect, data collected and not made use of, is of no value. Oh, hello?
Hello, we can hear you. Go ahead.
We can hear you, sir.
We can't see I can't see the slide anymore. Can you go back
I
to
can
the
see
slide?
it too. Mr. Shala is the one sharing it, isn't it?
Oh, okay.
Okay, let me, maybe the network threw him out.
Now I don't know which is the next slide.
Don't worry, we'll fix it now.
Okay.
Please let me know if you can see the slide.
Oh, well, it's yeah.
Is it
But
showing now?
you need to go, you are the last slide now.
So
Well,
just let
we know you've gone, I think you've gone past, we were on slide number, yeah, put it on slideshow, Shala.
no, I'm the one sharing because I cannot find Mr. Shala. I think.
Okay, please put it on slideshow.
Sorry for what I'm doing.
Yeah.
So does this help? This is where I followed up to.
Yeah, the slide before this one, the slide before this one.
This one?
No? We have.
I'm going forward now.
Yeah. Oh, no, you go back. Sorry. Yeah, keep going. Keep backward, back. No, you are going forward.
Sorry.
Mm-hmm.
Okay, let's go this way.
Yeah. Okay.
We're here, right?
In key stakeholders, yeah, community leaders, yeah. In fact, we've gone past this.
Yeah, I know. I'm just moving one by one here.
Yeah. Role of Americans, we've done that. Raising awareness. Yeah, okay, so let's start from here. Oh yeah, this is where we were. Okay. Youth and school health advocates.
Okay. So
yeah, thank you. Yes, so we talked about what the youth that is common now, technology, social media, to spread the message among their peers, to raise champions among themselves, to do works, to be creative and innovative in what they can do. Next slide, please. Next slide.
Yes, sir.
Okay, healthcare providers, of course, I think we've done all this as well, you know. They are, in fact, very critical, very well positioned in counseling, in testing, in providing care, in offering other collateral services for sickle cell disease, people with sickle cell disease. Next slide. So policymakers and research institutions, which I think we've also done, institutions help in genotype testing. Okay, now this where that no role of media. Sorry, go back.
I heard you have done it.
Yeah.
Is it okay, or I should still go backward?
No, one more. I think we are on media because I think the media one is also very important. No, you go back.
Sorry.
Mm-hmm. Here.
Which one? Health financing,
Yeah.
comprehensive care.
Click it. We'll say the one on. No, we haven't reached there. Go earlier slides. Ah, here. Yeah. Yeah, this is where we are. Yeah, media is very important. Media and the civil society organizations are very critical to our achieving the objectives for which we want to engage the community for sickle cell disease care, because they help to spread accurate and accessible information, combating myths and stigma, translate complex scientific findings into language that the public can understand, and bring the attention to underfunded SCD programs. Use the media campaign to encourage genotype testing at community level and collaborate with the influencers we have identified and celebrities and the faith-based organizations to engage the wider audience. And community education and outreach, they are very critical, but strategically positioned to achieve that. Running support groups and mentoring. Create platforms for citizens to report gaps or successes in demanding stewardship and accountability from the providers. I think they play an important role. And jointly organize advocacy campaigns leveraging on social media, storytelling, and community radio for consistent engagement. And this community radio thing, even America still uses, there's American community radio to disseminate information to a larger society. Next slide, please. Next slide. Role of, what about those living with sickle cell disease themselves? Caregivers. They can actually be great evidence providers for good works that interventions can bring, because they can provide it like testimony because they've lived through experiences. Ensure marginalized SCD voices, e.g. rural dwellers, women, children are heard and by decision-making processes and they participate. Help researchers and help workers understand what works and what doesn't work. In fact, they are great partners in getting us feedback from what we do and how we do it. Older individuals with SCDs and experienced caregivers can guide younger patients. They serve as mentors, to inspire them. Monitor the availability and quality of services promised by government or NGOs and the providers, and demonstrate effective self-management techniques such as hydration, adherence to medication, pain management, early consultation, uptake of cares, and also disproving all the myths and so that they bar people from taking up services. Next slide. Strategic actions. What are our strategic actions aimed to achieve? Next slide. Next slide. So the first thing is awareness and education. The focus area for community advocacy include awareness and education. And these are things that I've discussed, but we can just quickly run through them. For advocacy, for increased public knowledge about SCD, the symptoms, inheritance and care options, promote anti-stigma campaigns to challenge myths and misconceptions, and push for inclusion of SCD education in school curriculum and in community health programs. Next slide. What about access to screening and diagnosis? Okay, one of the key focus area for this, because we said that we should, part of what is good to do is to have the genotype determined early as possible. So we need to do a campaign for newborn screening and early detection programs, and demand genotype testing for at-risk populations, and support mobile outreach and community-based testing, especially for underserved areas in the rural communities. Next slide. Next slide. What about access to comprehensive care? What will be our focus? Will be to advocate for integration of SCD services into primary health care, at least, and this is why this sort of program is very important, because it's reaching large numbers of people who are concerned and who are involved in the care. We push for availability of essential drugs, such as hydroxyurea, pain medication, and folic acid. And also, like we said before, help to implement health insurance to cover sickle cell disease, so that out-of-pocket expenditure does not prevent uptake. And finally, demand access to specialized care units and trained healthcare providers at higher level. Health financing and coverage, I think I've just mentioned that. Can we move to the next slide? What about government policy and commitment? Especially even at primary healthcare level. At the local government level, we should demand implementation of national policies and frameworks for SCD management. And that is one of the responsibilities that the community groups, the youth, can take up, because they can exert further pressure on the government at local government level, and call for increased funding for services and for infrastructure. We mentioned about provision of drugs, hydroxyurea, making it available, and so on. Because currently now, it's not even generally available, even things that are cheaper than hydroxyurea. Advocate for legal protection for persons living with SCD, especially in the workplace, and also to avoid discrimination. Next slide, please. Research participation and representation promote inclusion of communities in the design, so that people living with sickle cell disease can easily understand why the research, what benefit the research will bring to those who are affected and to the community at large. Advocate for research on traditional beliefs and social determinants that are affecting sickle cell disease care, and push for locally driven research priorities that can help the communities that are and the peculiarities of our communities. Next slide. Next slide. Advocating for access to counseling and peer support services from schools, especially within the school health program, and promoting policies that support care providers, making, like flexible work hours, and so on, that can actually cause them, because if you look at it in rural areas, sometimes the health workers just come to work in only a few days, and few days, the other days, the facilities are locked up. We think that that will not work well. for sickle cell disease care. So we need to advocate that 24-hour coverage be provided, especially even in rural areas. Advocate for school-based support for children and providing first aid infrastructure, such as for hydration and so on, before referral. Next slide. This may not be so clear, but these are some of the ethical considerations in community engagement. And I think these were discussed yesterday, but maybe this will serve as, just can we go back to it?
Ethical Kinilawa. Sorry.
Yeah. It's down. Yeah, we're almost there. Okay, so these are some of the things to ensure participants understand the purpose and risks and benefits of what they are getting themselves, what they're engaging in. Also engage marginalized voices so that there's inclusion, and there's diversity and nobody's left behind. There's equity and there's equality. We use Professor Dejumo's words of yesterday, which I agree with, of course. Ensure representation across gender, age, and socioeconomic status. Protect personal health information, that is under ethics, and clearly communicate the goals and limitations of the interventions to the community members, and ensure the community benefits from the engagement, e.g., through education, through services, or through access to new knowledge or new care pathways. Next slide, please. Also, so that they understand the cultural beliefs around SCD and they can do away with, because culture is supposed to be dynamic anyway, and seek ways to align health messages with cultural values, and collaborate with traditional rulers within the communities and the community elders who hold the influence upon the community. Use culturally respected spokespersons and use local languages that are applicable and culturally acceptable to society, and adapt materials to the literacy level of the audience so that you are not speaking about them and they are following what you are saying. Recognize gender dynamics in decision-making and design separate spaces or inclusive approaches to engage both men and women appropriately. Next slide. Next slide.
Is there, sir?
These are practical considerations. We choose appropriate venues and times, consider transportation and refreshment and childcare when you're engaging the community. These are generally poor people. Equip community mobilizers and health providers and volunteers. These are points that are very important. They may look minor, but they are very important to achieving the success of that we want to achieve. Designing the engagement that can continue beyond one-off events. So that is to support sustainability, continuity and sustainability, and include mechanisms for community members to give feedback or raise concerns that they may have on our interventions. And finally, plan within available human, financial, and time resources while aiming for high impact and low cost strategies. Finally, in conclusion, community engagement is not just an add-on, it is fundamental to the success of any public health initiative, especially for sickle cell disease, and in fact, all NCDs. By meaningfully involving affected individuals, their family members, community leaders, youths, and healthcare workers, and policymakers, we ensure that interventions are culturally relevant, they are ethically sound, they are locally owned, so there's sustainability and uptake, and it is impactful, leading to early detection, improved care, for those who have been found to have sickle cell disease, reduce stigma and provide better health outcomes for people living with sickle cell disease. Last slide. I thank you. I hope we've been able to benefit something from our discussion, but if there are questions, I'll be glad to take them. Thank you so much.
Thank you so much, sir, for this very insightful and impactful lecture on community engagement regarding sickle cell disease. We expect no less, sir, and we are grateful that you were able to deliver this to us. Thank you so much, sir.
Thank you. Thank you.
Now, we have Emeritus Professor Oladoshu Ojengbe giving us this lecture, and I know that there will be questions arising from it. People want to know more or have some clarifications. I've been looking through the question session, and I can see that maybe people's minds are focused on the post-test, or that we totally understand everything Prof has been saying. I can't find much question. But in order to kickstart that, I think I will ask one or two questions, sir.
Okay.
There was a question from yesterday that we did not answer. Somebody was asking what to call people who have sickle cell disease, since being called sickler has been regarded as discrimination. And I've heard you this morning referring to them as people living with sickle cell disease. I know that they have support groups and they refer to themselves, or they are called warriors. So, sir, what will you say to how these people who happen to be living with sickle cell disease should be called, how they should be referred to, in order not to infringe on their rights or discriminate against them, as the case may be? Thank you, sir.
Thank you. When the issue of warriors started, it was actually as a reaction to the observation you made, because people were saying sickler, the sickler, and once you hear the word sickler, you are thinking of the worst evil on earth, and even at that time, we pushed those who were living with sickle cell disease for them to even believe that they don't they don't have equal opportunity to survive life. There are many, I'm sure we all know about a governor, a former governor from the north, who said when he was talking and they said, you people will go after you and kill you. Say, what is he waiting for? That no one has ever lived up to 60. He's the first one to live up to 60. All civil cell killed everybody. So he's already a champion. He was thinking that was a great achievement, but it is. The truth is, they are sickle cell is not their fault. It's a genetic issue. They are living with it and they're surviving with it. So technically, as clinicians, we can use the word people living with sickle cell disease. But things like sickler, of course, like I said, the champion thing came from NGO sector to combat the discriminatory language that was perceived being used for people who have sickle cell disease. Thank you.
Very much, sir. The questions are coming in now. So okay. I will take this question from Aaron Apia Ubeng. He said, what activities do genetic counselors, maybe it means roles, do genetic counselors play in the SDG of our countries to ensure that sickle cell disease are curbed from the grassroots? That's the question, sir.
Yeah, thank you. Thank you for the question. The truth is that genetic counselors, genetic counseling is in fact is new, is recent. The focus on it is recent. And permit me to thank some of our colleagues, Professor Nejumo, Toyanabu and Unodu, who have taken up the issue of genetic cancer. Genetic cancer became very important only in the last maybe 5-10 years. And we are just evolving through it. Well, genetic counselors, of course, have a great role, like we said now during this presentation, to engage community members to understand the facts about sickle cell disease, the genetics of it, and dispelling the rumors and misconceptions, and helping them to accept that genotype determination is very important, is critical to early diagnosis and early institution of clinical care. So there is a role they can play. There is a role for everybody. And indeed, apart from those who provide clinical services, all the other social services like counseling, like encouraging, motivating, it's a responsibility for all of us. I hope I've answered the question. Hello? Hello?
Hello, sir. Thank you very much, sir. You have answered the question. Maybe we should take, I don't know how much time we have. Okay, we still have like 5 minutes
1 minute
or so. So let me quickly ask some of these questions that have been.
It's 7:50 already, though.
Yes, sir. In the next 5 minutes,
just
we
one
will
more
round up.
question. Just one more question.
One more question. Okay,
Yes.
let me look for one that is not related to stigmatization. Okay, somebody is asking if, okay, I'm trying to sort it now. Okay, somebody was asking if there are other alternatives to education on stigmatization. That's Abigail Agiewai Achipong. In our part of Africa, stigmatization is very ongoing. Aside introduction to our school curriculum, what other alternative can we use to curb this stigma? And another person is asking if there are fundings to aid in, can one get funding in supporting SCD patients? I don't know what the person means. That's Adedapo Ismail.
Yeah, the first question, I think the discussion, the presentation we just finished, dwells extensively on how we can advocate or educate community members by different groups, by healthcare providers, by those living with sickle cell disease, by community leaders, by religious leaders, even by the social media, even by the youth, by school, health education. I think we listed everything. And so if I can refer that person to the slides, I'm sure it will be there. You will find detailed accounts of what people can do to dispel myths and misconceptions.
Thank you very much, sir. And at this
you.
junction, we want to say a very big thank you to you for your time and for giving us these explanations. Now everyone can go back to their various communities and start to do something. It is very, very important that we involve the community. Without them, any intervention that we may want to do will not fly. So community engagement is very succinct and very integral to our plan and our interventions regarding sickle cell disease and control in our countries. Thank you so much, sir. And this junction, I want to hand over to Professor Priska, who will then inform us on what is next.
Thank you. Can you hear me?
Yes, ma'am.
Okay, thank you very much. Everyone now, I know there is anxiety of post-test, but let me just encourage us that it's not how do I put it? It's not an examination. It is just to make sure that learning has taken place. And the first question I want to ask in that regard is, Mr. Shola, have you sent Prof's presentation to everybody? As we said yesterday, it's very important. Hello, Mr. Shola.
This lecture that we just finished.
Yes, it was with us yesterday, and I asked that it should be sent. If not, please go ahead and send it. Go ahead and send it now. Yes, they need to have as many presentations as we have permission to share with them before we do the post test. Thank you. Please just go ahead and put in their something before we continue. And we have about 6 minutes now for anyone who has any question of all that has been said from beginning to today. Is like revision. It's very important for every one of us. I want to appreciate the moderator. She has, quickly wrapped it up on that session that every one of us should go ahead and then do likewise all that we have learned. And I really, really want to appreciate us for these 4 weeks. It's been hectic for all of you, and it's been hectic for all of us. So on both sides of the divide, it's been hectic, it's been sleepless nights, it's been preparatory meetings and so many things, just to ensure the success of these 4 weeks. And we really want to return all the glory to God for good health, for sound mind, and for granting all of us the privilege and the opportunity to be exposed to have this together. So thank you so much. If you have any question, please, now these are not questions related to the last presentation. Any question from any area regarding the post test or regarding the operations and everything, immediately it is 8 a.m. The post test is going to be launched, and that is going to take us to 8:55, when I will come back in the last 5 minutes to give us vital questions. We should finish that post test in 30 minutes, actually. So once the person receiving the answer says you are done, we might stop, we might return before 55 minutes, because it's a thing that can be done in 30 minutes. But because we understand the importance of post test, we have added more time to make sure that everything is fine. So we have 4 minutes for you now. If you have any question, please go ahead and ask. Mr. Shola, can people be allowed to speak so that it can be faster? Or if you can raise up your hand, I don't even know how best we can do that. And I hope the background picture is going on as we have agreed.
Raise up their hand.
Okay. Mr. Shola said you should raise up your hand.
Let participants raise up his or her hand if she wants to speak.
Okay. And it will be attended to, please. Once you, Mr. Shola, let me know if there's any hand up and you want to unmute. But while I'm waiting for that, let me quickly contribute to the last question, second to the last question. Somebody asked about SDG and genetic counseling. Prof has given fantastic answer, and I appreciate that the fact that genetic counseling is very new in our environment. In other places, yes, there's a lot. In fact, it's a distinct specialty. You need to have a master's degree before you can go for it in the US, in other parts of the world. But in our environment, we don't have the luxury of all of that. And so what we started with a short course on genetic counseling of people that are experiencing cancer. And then from there, we moved on to people experiencing stroke. And then we moved on there to people experiencing diabetes mellitus. And now we are on the bus stop of sickle cell disease. Like Prof has said, genetic counseling affects the prognosis, the diagnosis, and everything that concerns almost all non-communicable diseases. And so for newer people who will be coming up for genetic counseling, I encourage them to go through the pathway that take care of all non-communicable diseases and not just focusing on particular one. But in this workshop, our focus and our emphasis is on sickle cell disease. So specifically to that person's question about the role of genetic counseling in SGD, Prof has given all the answers in the slide, so I encourage you to go there. But the only thing is that it's not tied to specific SDG. So if you look at all the SDGs, you see the one that is applicable. For example, SDG 3 is talking about good health and well-being, disease prevention and management. And genetic counselors help individuals understand their risk of inherited conditions, in this case, sickle cell disease, and then they are able to provide them with information that we assist them to make informed decisions about screening, early intervention, management strategies, and so on and so forth, which will not only reduce the incidence and prevalence of what we have, but will reduce morbidity and mortality, from sickle cell disease and all other diseases that have genetic implications. The reproductive health, the role of genetic counselor in this, Prof has said it, Obi said it in our presentation, and so many people talked about it. Genetic risks that were talked about here, personalized healthcare, and all of those things. If you go to SDG 5, gender equality, Professor Adebayo yesterday told us a lot about equity and inequity and made us to understand the differences. So as we empower women, as we address health disparities, all of those are tied to SDG 5. And if you look at SDG 10, specifically, that's talking about reduction in inequalities. And I think SDG 17 talks about partnerships for the goals, interdisciplinary collaboration. Genetic counselors work closely with other healthcare providers. We see in all of these things we're doing and we're presenting everybody. We're showcasing interprofessionalism. You see, a nurse comes to give lecture, a psychologist comes to give lecture, obstetrics and gynecology comes, hematologist, everybody, so that we are also displaying something to you, that genetic counseling in our environment, while it is not yet a full-time separate entity as a profession, we are handling it with individuals who have exposure to the training, short courses, and what have you in the area of genetic counseling. And all of us are involved in all of this at this point and at this juncture. And I want to say, Mr. Shola, please let me know any hand up. My time is 8 o'clock. So that means there's no clarification. All the questions are clear.
There are many hands on. There are 10
I said
hands.
stop me when there's any hand. That's what I'm just with whining
Oh,
away.
I thought you were still talking. That's why
Oh, sorry. It's okay. Okay, let's spend 2 minutes to do that. So all presenters that are in, be ready to answer any question. Just go ahead. We just take 1 or 2 because I wish we have recognized that on time. Mr. Shola, please. Yeah, unmute.
Mr. Please.
I cannot hear you. I don't know if other people can hear you.
If he's not ready, Mr.
No, I didn't hear
Zacchaeus
it.
Olofin, can you please unmute?
Yeah, thank you very much. Yes, I wanted to
Zacchaeus
ask.
Olofin is about to.
Yes. Thank you. I want to ask regarding hydroxyurea. From my training in medical school in usage, before hydroxyurea is commenced in pediatric age group, transcranial Doppler ultrasound scan is usually done just to know if the child is predisposed to having stroke, and it's also used to adjust the dosage. But the speaker did not mention that. He said from 6 months, hydroxyurea could be commenced. Then regarding Professor Ojengbe's Emeritus Professor Ojengbe's lecture, he spoke about insurance, including sickle cell patients in the National Health Insurance Scheme. My own concern is that most insurance schemes don't prioritize the use of branded medications, because 2 days ago I saw a patient with sickle cell, and apparently she was on generic medications and she wasn't getting better. If I had to change her to the branded ketrazone and levofloxacin, and within 12 hours after commencement, she's was on call. I was not called at all to attend to her because she was getting better. So my advocate is that not just that they should be included in health insurance scheme, but proper health insurance so that they could have access to better medications.
Okay, thank you. Thank you very much for your question. Professor Ojengbe is in. He will attend to the second part of the question you raised. I am not sure if Dr. Fakore is in, but generally speaking,
I'm in, ma'am.
Okay, thank you. I think,
yes,
okay, yeah, just go ahead. On the TCT, we measure blood flow velocity in major places. They are used, for stroke, to discover stroke complications before placing patients on hydroxyurea, especially in pediatrics. So he said you didn't mention anything concerning that. What's your take? Thank you.
Okay, thank you very much. Yes, regarding the use of hydroxyurea in the reduction of stroke risk. So it's actually hydroxyurea is being used, is part of what, as we said yesterday, that hydroxyurea should be prescribed to all children with sickle cell disease to reduce the risk of complications. So one of those complications is the risk of stroke. So it's been found and it's been documented extensively that hydroxyurea is capable of reducing the cerebral blood flow velocity. So which is actually when it is high, above 200 centimeters per second, that, the risk of developing stroke is very high. So I know that Professor Lagunju in UCH has actually done extensive work on that, and there are some other studies in Kano, even a clinical trial in Kano and some other places. So that is one of what hydroxyurea can do. It's capable of reducing stroke. And even as a matter of fact, and there's also the aspect, because for those that have the range values, we normally place them on transfusion so that to prevent the risk of the stroke. So in our environment that, access to blood is actually reduced, and, talking about even the safety and also especially the cost. So hydroxyurea at a very high dose can actually cover for blood transfusion. Yes, blood transfusion is the mainstay, which is the foremost. So, but in the absence of that, if we can place the patients on hydroxyurea at a high dose, it can help to reduce stroke risk in them. Thank you.
Okay, thank you very much. I think the question he wanted to know is about TCD that you didn't mention in your presentation, the issue of transcranial Doppler ultrasound, whether that they do that for patients in UCH, that you didn't mention
whether it's mandatory.
Okay, yes. Okay, for TCD, is actually, as the recommendation actually states that all children with sickle cell disease between the age of 2 and 16 years of age should have regular TCD, annual TCD. So, and those one with the range values can be more frequent. So, and the reason for this is to be able to detect those who will come down with stroke, so that we'll be able to prevent that, using the blood transfusion and or hydroxyurea that I mentioned earlier on. So TCD is very important.
Okay, thank you very much. So what we are trying to say is that, yeah, the fact that maybe I'm not sure whether it was mentioned or not mentioned, that is to show to us that all presentations are not all inclusive. The fact that anything is not mentioned here does not mean that, if it is a standard practice, that is not necessary. No, not at all. Please. So let's go ahead and keep reading and keep doing a lot of things that we can do. In UCH, some years ago, hydroxyurea was a very, very serious considerations. We had cases of patients in Adeoyo, and we had a support group for them in Emeritus. And the issue of hydroxyurea was really, 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 really very, very, very controversial. But today, literature has moved on, as we have had in all the presentations that we have been discussed. So I would just suggest that there are some resources and materials, reading materials that have been dropped by Obi. Please, let's try and read them and go ahead and read more and more and more and more and more. So if we have left medical school yesterday, by today things might have moved on, and then we should just go ahead and keep reading. I want to thank you very much for your question. And because of time, I'm afraid maybe we should take just one more, so that at least we give people opportunity who have raised up their hand. And I'm glad that other people are here who can attend to other questions as well. So let's just take one more. And after that, please, everybody get ready. Don't tell me I didn't say the link. Don't tell me when the link was posted, I was not there. And if you know anybody who is out anywhere, please call them that it's time for post-test. Post-test is as important as the life wire of all that we have done so far. And we don't want anybody to miss it. So let's get ready, prepare ourselves, and be ready. Once you see the link, just go ahead and start. And there is timed. So there is time to eat, but the time is ample, is a lot. You don't need up to that to be able to finish. And once that time is over, we come back to give you information about what's going to move forward, who are going to proceed to the next level, the hands-on training in Kumasi, in UCH, and in Abuja, University of Abuja Teaching Hospital, and all of that. So it's important that we stay on to the end, please. We may extend a little bit beyond 9 a.m. today, but we'll try as much as possible not to. So just one more question after this, especially if it relates to the post-test or anything that concerns the post-test. Please do ask now. Thank you, and over. Mr. Shola.
Yes, you can unmute yourself if your hand is up, please.
Thank you very much for the opportunity. Please, concerning the hydroxyurea, I know there's a range of dose to be given. At which point, how fast do we increase the dose once we start? And then at which point do you say it's okay? Let me give an example. If a patient is doing well on 20 milligram, if a patient is placed on 20 milligram per kg, and the patient is doing well, as per you saw that there's the WBC has decreased, crises have reduced. Do you just maintain on that dose, or you still try and increase it? Because I've had some situation where some patient relatives are saying, well, this child is doing on this dose. Why do you have to increase? And I know that there's also a maximum dose. So is it that we use their clinical response to know when to stop and when to increase, or we just gradually increase it? And then how often do we increase? Is it after every 3 months or 4 months or 6 months? Thank you very much.
Okay, thank you very much for your question. I'm sure Dr. Fakone, who did the last presentation on pediatrics and sickle cell disease, will respond to that. One of the confusion that happened in the state hospital, where we had most of our patients coming from then, that's quite some years now, though, was that, you know, when you have these children on hydroxyurea, it's important, two factors that are very critical for us. I know OB dropped something for us, a reading material that talks about WHO or NIH prescription on the use of hydroxyurea as a standard practice, as a gold practice for, you know, children with sickle cell disease. But I know the issue of vaso-occlusive crisis and monitoring of the neutropenia of these patients' blood count is very essential. And that's what we had problems with in those patients that were coming from remote areas. Some of them do not understand the importance of, okay, if you have been placed on maybe this particular initial dose, and then the child is having vaso-occlusive crisis, which is a very important indicator that we think that this is going to be very helpful for, then you should just be increasing it irrespective of whatever it is that is happening. And then the issue of blood count, whether it's neutropenia, you want to check for anything, was not put into consideration in those remote areas. They were just thinking that, oh, this drug works for this child is on it, they gave it to me, this place is working, oh yeah, you too, come and start giving it to your child, which was a very serious issue for us in that support group then. They were coming to UCH, but they were coming from different remote areas. Like we have had, a lot has moved on forward in this presentation. And please make sure you have that reading material that will be dropped for us. So Dr. Fakone, please just answer this and we will end on this. I am sorry if other questions are not taken care of, but if you can do me a favor of dropping the question in the Q&A session, I will ask Dr. Vincent or Dr. Riaku to please help us take a snapshot of those questions and then they will be responded to. But thank you very much for your incredible participation. Over to you, Dr. And let's get now.
All right, thank you very much, ma. So to answer the question, you know, straightforward, the starting dose for hydroxyurea is actually in children 15 to 20 milligram per kg, then in adults 10 to 15 milligram per kg. So, and the dosage is usually expected to be increased by 5 milligram per kg every 2 months until one gets to maximum tolerated dose, or the highest dose, which is 35 milligram per kg. That's provided you want to go as high as that. So I'm just answering generally now. The start dose, either 15 to 20 or 10 to 15 milligram per kg, then to be increased by 5 milligram per kg every 2 months. And in which case that will follow monitoring of the full blood count to see how the patient is responding to that. So, but having said that, usually from the experience, we find out that, you know, most patients, they do well even by the time that you start them on the 20 milligram per kg. So, but research also has it that the benefit actually increases with increment in dosage. So, but again, the more you increase also, then there's tendency that, the side effects will crop up. From our own experience and even the publication that we've made, we discovered that, most of the patients, by the time we start them at 20 milligram per kg and get it to 25, they are doing very well. And beyond 25 milligram per kg, then some of them started having, all those cytopenia, although which is not a problem that can readily be reversed anyway. So there's also the concept of fixed dose regimen, which could be fixed low dose, fixed moderate dose. So for instance, if you are actually practicing in a place that you're not able to monitor, the patients regularly, or maybe there are some constraints that the patients financially will not be able to be coming for follow-up. So if we place them at the 20 milligram per kg start, I'm talking about children now, they can actually do well there in such a way that the frequency of monitoring is reduced. And all these that I'm saying, there are also now research, backing up the fact that, with the low dose, fixed low dose, the frequency of monitoring is reduced compared to, the what we call the escalated dosage regimen. So, and both are okay. So, as Professor Adejumo also said, the trying to increase is also based on the response of the patient. So if you place you start a patient on the hydroxyurea, yes, you increase once and they are doing well, you can actually just maintain them on that. So from experience, if some of them could actually be crisis free for a very long time, and at the point they start having crisis again. So it's expected that you actually check your dosage, because children are growing, so to make sure that the milligram per kg with the weight increment is actually balanced. And if that is not the problem, then you can also step it up, and by so doing you discover that they become well and they get stabilized and everything continues well. So that is actually the way that the hydroxyurea should be used. The starting dose increment of 5 milligram per kg after every 2 months, not before then. So that's the guideline and the recommendation.
Thank you. Can we have the guideline? Can we have the guideline in the resource? We actually put something together like a genetic album for sickle cell disease, but we've had so much going on, and the pressure has truly been much. But I think we can collate all these resources and take note. There's no fixed address. Anything you have today, in the next 2-3 years, might have changed. But the cocoa is, let all of us just keep reading, doing other search and all of that. We've just come to whet our appetite with all that we have done in this course. There is so much more. But I will be glad if we can have all those guidelines, at least put resources put together in the genetic album for those who will be interested, maybe when we are done. I'm sorry, I know there are so many.
I'm happy to do that, man.
Thank you. There are so many hands up, and unless we agree to extend this session till many people are already programmed into it, and I wouldn't really ordinarily want to extend, but we are 17 minutes past the hour of 8 o'clock when we should have started the post-test. We have post-evaluation, we have post-test, we have housekeeping. So all the hands up, could you please forgive me up front by dropping your questions in the Q&A session, and then it will be collated. I am sorry. So it's 2 minutes to 8:20, and I will just invite the person who is going to take us to the post-test, and then she will launch it, and then she will tell us where to look for and what to do, and then we will just start. If there's any technical itch that you develop or you have any trouble with it, please, we are here. We may not be talking. We are here at the background listening to comments, and we will respond to you. All the program managers for this program are here. I have Mr. Aaron from Ghana. I have Mr. Shola from Ibadan. I have Madam Ijoma from Abuja. So if you are from Abuja, you have any specific issue, please just let us know, Madam Ijoma will respond to you. If you are from Ibadan, there's anything specific, and Mr. Shola will respond to you. And if you are from Ghana and you have any specific issue that is peculiar to Ghana, Mr. Aaron will respond to you. If it is general, the moderator for this morning, Dr. Oluwatoyin Aniago, is here to respond and then call attention of every one of us. Professor Ojengbe is still on. Some resource person are here. We have Mr. Bayomi, who will be taking us through hands-on in Ibadan in the laboratory session. I'm here. Dr. Fakure is here, and I'm sure Professor Adebayo Adejumo is on the background. I'm sure Obi may be somewhere too. So please, it is 8:20, and we need to. It is 8:19 now. We have just 1 minute. So, Madam Ijoma, can I invite you? Professor Ojengbe, did I see your hand up?
No, sorry.
Okay.
Sorry,
Okay, so,
Prof. Ijoma has dropped off. I don't know if Dr. Kutila can step in for.
Why will she drop off at this hour? My goodness. Okay, Dr. Kotila, are you there?
Yes, ma'am. Here, ma'am.
Are you able to, or I should call her wherever she is? She should drop back.
Okay, ma, you could reach out to ma, but I think she had sent the link. Mr. Shola will help to post up the link for the post test.
Okay.
But you can still reach out.
Okay, so please, Mr. Shola, go ahead and get the link out to people while I'm trying to get her. Please launch the link to the post test now. It is 8:20. Please take notes from the moment you click start. You have 5 minutes, but I will not suggest you spend up to that minutes so that we can quickly return. Please let us return for vital information as we move on. Thank you. Mr. Shola, over to you, please. Mr. Shola, please speak with us so that we know what you are doing and where participants should go ahead and look for the link. Has Mr. Shola also dropped off?
I don't think so. I think I'm still saying.
Okay, Mr. Shola, please respond.
WhatsApp group, please.
Some people are not on the WhatsApp group. Some people are not on the WhatsApp group. Take note. But at least
if you're not on the WhatsApp group, you're not supposed to be here.
No, it's not so. Just go ahead and drop it in the WhatsApp group first, and then we'll sort out the rest.
I can't post in the. I posted in the WhatsApp group. I can't post in the Q&A.
So just wait. Everybody, please return to the WhatsApp group, and if you are not in the WhatsApp group, just let me know, and we'll try and push it across to you wherever you are. It is at the time you have to, once you click it, that's when your timing starts. So it doesn't matter when you are starting. Please, everyone on the WhatsApp group, return to the WhatsApp group now and go and start your post test. If you have any issue, just put it on the Q&A session, and all of us are here. The moderator, Ms. Shola, will be monitoring to let us know if there's anything, and we'll get back to you. So let me go and try to attend to people who are not on the WhatsApp group. If you just send me a message, it will help me to quickly identify you and push the post test to you wherever you are. Thank you, and over for now.
Hello. Hello. Can anybody hear me?
Yes, I can
Yes.
hear you.
Yes,
Okay.
you're
Sorry,
right.
Welcome
my
I hear you.
network
back.
tripped off. Yes, somebody. I got a call. I'm back here. Please, if anybody has any questions about the post test, I'm here to answer. I don't know if you heard me.
We heard you. Thank you. I think people will be very
We can hear
interested
you.
now. Thank you. Mr. Shola, please send me the same link you sent to other participants now, please.
Yeah, it's on our group, ma. Just check the LOC group.
No, there are two there. There's one for test. Just send me exactly what you sent to me personally now. It's for us to be on the same page. Thank you.
Please, I'm seeing people saying that they cannot see that the page open, but they're not seeing the questions. Is that true for, like, how many people is this true for?
Maybe they should try and relaunch their internet. That shouldn't be.
Yes,
The
because it's
internet
just, we have
issues.
429 people here and 8 people are complaining. So
Yes, so please, the people should either change the location of where they are, or if it's possible for them to change their network to another service provider, they should try and do that. That's a network
okay.
issue.
Yeah, thank you.
Dr. Niago. Dr. Niago.
Yes, please.
Please, I want to drop off. I want to drop off.
Okay.
Why now?
Where are you? Good morning, ma. Good morning, ma.
We have vital decisions to make at the end of the post-test.
So, is it temporary or
temporary drop off?
Do some other things.
You return after the
Is it at LOC or at the general webinar?
No, as LOC. We need to debrief.
Okay. I'll join by 9.
Okay, so
I'll join by 9 o'clock at LOC debrief meeting. All right,
okay, that's good.
All right.
Thank you.
All right. Thank you, ma'am.
Please, for those of you who are doing the pre-test and you have been here, do not send this link to those who are in the other group. They are going to have their own training, as we have decided. We have agreed that we should share the data reimbursement to 2, and they are going to have their own training. We will meet very soon and decide when they are starting, and we communicate to them. And they are going to have their own pre-test. So they should not bother participating in this post-test if they did not do pre-test for this particular session. It will be a waste of time and it will be a lot of unnecessary work for us. I hope recording has stopped, Mr. Shola. Ms. Ashola, I hope recording has stopped. If not, please stop recording. Let everyone note that there's no point sending this link to people in the other group. They are going to have their own test. Please don't